There are several. I think in the practicing community, one of the challenges that faces cardiologists has to do with the continued uncertainty as to how we are going to make this transition from volume to value, and what the rules of engagement will be with respect to being able to plan, budget, and seek appropriate reimbursement for services provided. And being able to do that at a time in which we're also challenged to reduce disparities in care. And we're also challenged to reduce inefficiency and reduce cost is quite difficult for the average cardiologist, the average group practice, the average faculty practice. And these are issues that touch all segments of the practicing cardiology community, ranging from an academic medical center where I am to a freestanding community-based practice with patients who are seen at multiple hospitals, for example, within or even outside of the same health system. I think some of these issues also confront the VA hospital system as well. So emphasis on value, emphasis on quality, emphasis on cost effectiveness, emphasis on restoring some of our credibility in the eyes of the public are really top of mind. On the other side of the equation, there are a lot of challenges with respect to research funding, the future of clinical trials becoming increasingly more expensive, increasingly more regulated, increasingly more complicated, very difficult to execute over a specified time frame. And the questions as to whether or not we can continue to afford trials of anywhere from 10 to 20 to 25,000 patients over a time horizon of 5 years, and the millions of dollars that are required in order to bring something like that home. A lack of research funding at the NIH level, the stagnation of NIH funding over the course of the last 10 years, for example, these are issues. Where we're headed with training in cardiovascular medicine is also a big issue, I think, facing the cardiology community. The number of years required to train, the job opportunities that currently exist and will exist in the future for people who graduate from training programs, and pressure from CMS and elsewhere to begin to look carefully at the number of graduate medical education training slots that would be supported from government funding sources. Well, I think there were a couple of breakthrough treatments in the recent past. One, of course, is the ARB neprilysin inhibitor for patients with advanced heart failure, which I think was a startling contribution to the management of patients with heart failure and reduced ejection fraction that has to rank very, very highly. I think the continued iterations in transcatheter therapies for patients with aortic stenosis is also a tremendous highlight. I think that there will be leadless pacemaker systems that might take over in a short period of time, or subcutaneous defibrillators, for example, making it easier for us to provide very high-end interventions to patients with much less in the way of invasiveness is quite exciting. And I think that the recognition that genetics, the role that genetics plays in certain cardiovascular disorders is a highlight, and obviously may provide the kind of basic substrate from which observations could be made in order to help cardiology get to this level of precision medicine that our oncology brethren have been able to push forward. But they deal in a world of molecular mutations that allow them to identify the fingerprints of certain cancers and target therapy accordingly. And we deal in a world of polygenic disorders that can be also influenced by environmental factors that make it more difficult, I think, for us to find a single target to approach, say, all patients with hypertension, or a single target to reduce long-term risks of atherosclerosis or even atrial fibrillation for that matter. But cardiology is certainly poised to continue in that direction, and I think it'll be a very exciting future. When I was coming out of medical school, I was hoping to accomplish the care of patients. I was interested in a career as a clinician, compared with a career as a basic scientist, for example. And I had not had much exposure to population science or translational science during my medical school training. And so my near-term horizon was that of being a clinician. I think fundamentally the goals are the same. I think that most people start down a pathway of going to medical school with a sense that they can help, that they want to take care of people, they want to make a difference. And how it is they do that has changed, what the expectations are, how expensive it is to be a medical student, and the type of curriculum that we now design for medical students, which has changed considerably since in the more than 40 years since I first started in medical school. And I'm very happy that it has changed. And many people in my position spend quite some time, I think, wistfully thinking about the past and saying, well, it's not really the same and people are not as adequately trained. Well, there's a new reality, I think, that students need to approach, and things ranging from team-based care to the interaction with genetics and understanding disease states. It's a very complicated, very fast-paced world in which we live. I think what I'd like to see is, I would like to see kind of an acceleration of the use of mobile technologies and precision medicine in the assessment and treatment of patients going forward. I would like very much in my lifetime as a practitioner over the course of perhaps the next decade is to see the realization of big data in practice. I want to be a better doctor. I want to be more specific with respect to diagnoses that I can make and treatments that I can design. And I'm very excited that the future might allow me to do that.